Good afternoon, and welcome to today's 27th annual ITUB pre-conference. We appreciate those of you that are here with us today and also our virtual attendees. Obviously, I'm not Mary Mulkey. My name is Marissa Montano. I'm ITUB Director of Policy. So I'm here to welcome you today. And it's really my pleasure to be here with you all in person, our first in-person conference since before the pandemic. We're excited for today's speakers as well as the entire conference and hope it will be a memorable event for you all. I would like to take this opportunity to thank my colleagues, our awesome ITUB team who put this amazing event on today. I'd also like to thank our generous sponsors, especially our gold sponsors this year, Anthem Blue Cross and Kaiser Permanente, without whom this conference would not be possible. We encourage you to visit our sponsor booths that are set out in the lobby just before these doors during the breaks and throughout the conference to connect with those who have supported this event. ITUB's broader work is funded by three core funders: the the California Healthcare Foundation, the California Endowment, the California Wellness Foundation. We thank you all for your ongoing support, especially during this transitional time. I'm excited to jump into our first panel, but before we begin, I wanted to give an extra special welcome to first-time ITUB conference attendees and to provide a little bit of background for those of you who are not familiar with ITUB. ITUB is a 27-year-old health policy nonprofit and convener. In addition to this annual conference, we put on more than a dozen policy and regional work groups across the state and produced in-depth issue briefs and high-level fact sheets. At ITUB, we have three core focus areas: coverage and access, delivery system transformation, and the future of health. The mission of ITUB is to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. ITUB seeks a health system that is universal, accessible, affordable, effective, and equitable. As an independent nonprofit organization dedicated to improving the health of Californians, ITUB views are its own. And now for a few reminders. Please turn your cell phones onto silent, and you can access the complimentary Wi-Fi using the network and password information shown on this screen. For full access to all conference materials and information, please download the conference app. To download the app, please search Expo Pass wherever you get your apps. Once downloaded, open mobile app and select login, and enter the same email you used to register and click send magic link. Note that if you do not use the same email, the system will not register you for this or recognize you for this event. Verify your email by clicking the teal mobile magic link button in the email from support@exposet.com. The Expo Pass mobile app will open and you will see the event you are registered for, and you're in. If you need assistance with the app or anything else, you can visit our team out in the lobby at the info table. Now it is my pleasure to announce our first panel, Policy Perspectives, the Future Needs of calaim. As many of you know, our pre-conference is based on what ITUB learned during our previous year's regional work groups. We held our 2022 regional work groups this past summer. And unsurprisingly, we focused this year on calaim implementation, checking in with our local healthcare delivery partners for updates on how the initial implementation efforts were going around the state. We heard nearly unanimously in every single work group, pretty much, that we were building a plane. We were building the plane while we were flying it. Those exact words every time. And believe that thoughtful implementation that breaks down silos is what will make calaim succeed in providing person-centered care to Medi-Cal members. In our work groups, the highlights, key takeaways that we identified were that communication is key at every level, that it's important to meet organizations where they are, and finally, that both flexibility and standardization play an important role. And if you want to know more, we have a whole publication that you can dive into. Kicking off our pre-conference event with a calaim policy perspective panel, we will hear from speakers on how calaim holds a promise to transform Medi-Cal into a person-centered delivery system and what is on the horizon as implementation moves forward. With that, I will introduce you to our esteemed moderator, David Panish. David is president of California Health Policy Strategies, a Sacramento-based consulting group. Previously, he served as external affairs director for Covered California and was part of a core senior leadership team responsible for standing up and launching California Health Benefit Exchange. Before joining Covered California, David served in the California State Legislature for over 30 years. David graduated from UC Berkeley, and in his spare time, which I just learned this a couple weeks ago, David plays and sings classic rock tunes along with some originals in the Sacramento Remedy 7 band. And with that, I'm going to hand it over to David.
Thank you very much. And yes, if you want to see me in action, we will be playing at Chando's on February 16th here in town. So David Panish, and it's really an honor to be in person for this event. I think this is the first in-person ITUP event in 3 years. 3 years. And so this is the first panel of the first ITUP conference live. So no pressure, you guys, but try to make it interesting. It's great. ITUP brings together so many people, and I recognize many of you in the audience. I have to say that part of, if you looking back at how we got here, which is kind of I want to bring you back to the topic of today's panel, but for most of my career as a staff guy in the legislature, our focus was on how to expand eligibility for Medi-Cal and for getting as many people covered as possible. So, the focus was always finding different ways of covering everyone. And, the truth is that pretty much now we've done that. We have achieved when we finally next year start to begin to enroll all of the undocumented Californians, we're going to pretty much hit there. And so the focus is now less on expanding eligibility and more on how to improve quality and equity. And that's kind of what what calaim is attempting to do. How do you serve people that are the most difficult to serve, that are hard to reach, that have complex, serious cases that often fall through the cracks? We started with this about 7 years ago with whole person care. People said, well, maybe if we started to address people as individuals and address them as a whole person, maybe we can start to get there. Or if we can find different ways of targeting different populations that have very unique needs, that are people who are hard to reach, maybe that's a better way of providing these kinds of medical services. And then also getting into things like social determinants of health, which is something that we've always talked about. So the administration, both under Jerry Brown and now under Governor Newsom, have launched the calaim proposal, which began eligibility about a year ago and is phasing in over time. What you're going to be hearing today are a panel of people who are involved in different segments, different aspects, and different populations related to calaim implementation. We're going to start with Lisa, where's Lisa? Okay. Lisa Chansawan, who's been around also, everyone here, this is an old crowd. I mean, you probably have like about 400 or 500 years of experience in healthcare right here. So Lisa's going to give us a quick overview of what her perspectives are at a state level. What are you seeing? What kind of trends? What kind of implementation challenges are we facing? And I don't want anyone to use the metaphor of we're building the airplane while we're flying the bicycle, or, you know, or let's move on from that. We know it's challenging. We know it's hard. And we also know that it's going to get done. So Lisa, take it away.
Well, can everybody hear me? Awesome. Let me know if I'm not loud enough and I will definitely turn it up. But it is such a pleasure to be here with all of you. ITUP is near and dear to many of our hearts, and this is such an important conference in California when it comes to our state Medicaid program, Medi-Cal. Today, I'm going to talk about calaim sort of writ large, but also really focus on the enhanced care management, community support side. But I want to at least start and acknowledge that calaim itself is comprised of so many different initiatives. These initiatives build infrastructure, it fills our gaps in our Medicaid knowledge. And really, you know, David started us off talking about how we've evolved as a state. We've gone beyond issues of coverage and access to really how do we make our Medi-Cal better? And so when we think about this, we need to really take a bigger, broader approach because there are a lot of moving pieces within calaim and also outside of calaim that calaim is going to work in conjunction with. And I'd be remiss if I didn't mention some of the other state initiatives such as AB 133 and the data exchange framework, or even the children youth behavioral health initiatives, which are key critical components of the delivery systems being built a little bit outside of the calaim framework. And so let's talk about enhanced care management and community supports. These are key critical programs that are really helping us bridge silos between healthcare delivery systems and social services. We've been talking about the importance of social determinants of health for over several decades. Now, this is our opportunity to really do something about it and build out the delivery system infrastructure and services that would allow your doctors, your provider to really understand how you as a patient is faring in community settings. So what does this really mean? I talk about it in the context of the delivery system. You know, most of our delivery systems are systems of sick care. They're designed for to support you as a patient when you actually have a medical condition and when you show up in the doctor's office or in the hospital settings. But it doesn't really have the eyes and ears that really understands how you're faring in community, what does day-to-day life look like, and what are those social needs that are hampering your ability to manage and support your own health. And so for me, that's what calaim really represents, an important opportunity for us to redesign our delivery systems, build out components that would support our real understanding of how some of our most vulnerable patients really do fare in community and not just when they're sick and showing up within our delivery systems. There are 14 community supports. These are all optional, of course, but the goal is to really show the evidence of by providing that intervention, how do we support and stabilize an individual's health so that they are able to have healthy, productive lives in community settings, not within institutions. And we currently have 8 populations of focus that have been named. There are new populations of focus that are also added as we learn and really seek to understand who really is the most vulnerable within Medicaid. And of course, as with all new initiatives, there are always bumps in the road, right? I mean, we talked about it a little bit already. Last year was very challenging. It was a transition year from whole person care and health homes programming into a new structure. Many patients were transferred, but some didn't make it through that process. And so, you know, finding them, reaching out, getting them back into the system, getting those needs met is an important activity. You know, before under whole person care and health homes, there were TELs, targeted lists where we knew that some of these individuals had needs where you could go and find them. That is no longer the case. So we really need to build new approaches, new strategies to really find these individuals who have that need. And it's not just engaging at the individual level, but also at the provider level. Not all providers know about calaim, understand the benefits and how to plug in. And so that education probably needs to go even further and deeper. And of course, none of this happens without funding for us to redesign and build some infrastructure and capacity. Last year, there are several funding streams that are now made available to build this infrastructure, to support workforce capacity. And some of that funding didn't flow until late last year. We're really excited and really hopeful that more of that funding will flow in 2023. And looking ahead, 2023 is going to be a pivotal year. There are several key policy elements coming together. I've mentioned AB 133 and the data exchange framework. That's going to help support, enable some of the much needed infrastructure for data sharing and interoperability. We've also invested in a population health management system. That service is supposed to come online this year, and that's going to help us really understand the longitudinal history of some of our most vulnerable. And so having some of these pieces come together at this pivotal moment will really help us bring some of these programs to scale. And, it's not without challenges, right? We have new populations of focus coming online, children and youth, justice involved. And I gotta say, shout outs to California for being the first state in the nation to get justice involved populations covered as part of our waiver. So that is a huge and important change, is precedent setting. We also need to maintain our current infrastructure and provider capacity. I mentioned TELS. TELS are really important because we need to continue to have a pipeline of patients where we're identifying them, feeding them into the system so that providers can engage with them, provide the interventions that are needed to help support them. But if you can't find them, we have a lot of providers who have built capacity. They're waiting for these patients to come. And if they don't come, what do you think happens to that capacity? That capacity, they may not be able to maintain that staffing, maintain that capacity if we don't fix the problem of the inflows versus the outflows. So what's next? We're really excited about some of these major pieces coming together. But more importantly, I think when we look at successful systems transformation efforts across the nation, a common element that we see across them is the need for a backbone entity, a neutral entity that can bring everybody together, can identify challenges and needs. And how is California going to do this? Well, we're going to come together through a collaborative planning effort. This is under a new initiative called PATH Collaborative Planning and Implementation, PATH CPI. And what's really important about this is, and I just want to give a shout out to many of the other facilitators in the room. There is going to be PATH CPI facilitators in every community across the state. And so, if you don't know who your PATH facilitator is, I would go on the PATH website and find out, because that's how you can plug in and find out how is calaim implementation happening in your community. It's an opportunity for you to participate in those planning efforts. And so I'm going to invite all of my PATH facilitators, wave your hand, stand up, any of you who are out there. I know there's quite a few of you. Just want to acknowledge that this is an important piece of our planning efforts to come together. And every community is different. We can't use the same strategies, same approaches. We have to figure out what is possible within the local resources. We have to engage different providers and county partners where they are, and really essentially bring everybody along. Our firm, Transform Health, has been named the PATH facilitator in Los Angeles, Sacramento, and a three-county region in the Central Valley, Fresno, Madera, Kings. And each of our regions are very different. And I'll give you an example. In Los Angeles, we have lanes, there's manifest medics, there's several avenues for health information exchange and health information organizations that could help providers address interoperability. That is not the case in the Central Valley. And in Sacramento, we're still exploring how do we build a social health information exchange. And so that gives you an understanding that every community is going to look a little bit different. The needs are going to be different. We've heard from many providers as well as plan partners that penetration of the different provider types, the different community supports really vary by community. In some places, we have enough housing navigators, and others we don't. IT interoperability, I mentioned, there's a wide-ranging understanding of what interoperability really means, what it really looks like. We need to help everybody, all the providers, including the smallest CBOs, really understand how they can exchange data and participate in this type of programming and engage with providers upstream and downstream. I would be remiss if I don't mention some of our workforce challenges. That's a challenge that we see across many communities, particularly for allied professionals. There's a little bit of confusion right now across many providers in different localities, different counties. When do you deploy the ECM community support rate versus the CHWP APL? Understanding which mechanism and which lever you're drawing upon for that funding is really important. We also know that there aren't enough allied paraprofessionals. For example, San Diego County did a study and they found that over the next 10 years, they need over 7,000 paraprofessional CHWPs, peer support workers. They currently only have a little over 4,000, and that's just in one community in our state. Can you imagine what it looks like in other communities, particularly in the rural north? We have to understand how these issues impact our ability to build calaim capacity and inputs. And finally, I'll leave you with this final thought. A lot around this ECM CS program is around network building. We are building networks of CBOs who can support and provide those health-related social need interventions to address patient social determinants of health. And if we can build this network that wraps around existing planned clinical networks, then we're missing a key piece of the delivery system. And so a lot of effort right now is underway to really help and understand how do CBOs engage. We see a lot of the larger, more sophisticated CBOs, they're the ones who are able to secure contracts, build up their programming, secure staffing. But sometimes we need the smaller CBOs who are community targeted, who really go that last mile. And these CBOs often struggle in transitioning to working with managed care plans. They're used to grant-based approach. Managed care is a completely new language for them to learn. And so just even understanding how this changes their business operations is a real struggle for some of these CBOs. And we're trying to reach in, find them, support them. And that is going to be a critical piece of our work this year. So I'll leave it at that. Thank you for giving me this opportunity to share my thoughts.
Thank you, Lisa. All right, I'm going to do a pop quiz here just to see if people are paying attention. Let's see if we can name the 7 major enhanced care management populations of focus. Who can name them? What? Homeless, that's one, or people experiencing homelessness. What? That's one. High utilizers, they have a new name too. I forgot what it was. Which is broader than, so people with behavioral health issues. Who else? What is that, 4, up to 3, 4?
Justice involved.
Justice involved? Which one? High-risk children, yes? Which one? At risk of it, and what kind of institutionalization? Okay, I think we covered, did we get them all? Okay, so for the rest of the discussion, and I do want to leave a lot of time for questions and answers, or maybe just questions, because who knows what the answers are. But we're going to now take a deeper dive into some of these specific populations of focus. And we have experts who are representing, who are in the midst of implementation for 3 of those. So we're going to start with Michelle Cabrera, who is the executive director of the California Behavioral Health Directors Association. So she is right smack in the middle of implementation for the behavioral health population of focus. This is one that always falls through the cracks over the years, where we have separated and segregated those with behavioral health issues from sort of the broader medical delivery system. And Michelle, I'm going to ask you to come over here so that I think we're missing this side of the building if we just do it from our panel. So
Great. Hi, good afternoon, everybody. Pleasure to be here. I just wanted to kind of start out maybe with a little bit of level setting, because I know I learned like several things from listening to Lisa just give the broad overview. So the county behavioral health agencies who I represent are responsible for the delivery of specialty mental health and substance use disorder services for Medi-Cal beneficiaries who have a need for specialty care in terms of those conditions. My members operate as prepaid inpatient health plans under Medicaid, which means that they are subject to all of the same rules and criteria that Medi-Cal managed care plans are when it comes to things like the managed care final rule, network adequacy, timely access, as well as parity, law enforcement, et cetera. One thing that I think is really interesting, however, from the vantage point of county behavioral health, is that county behavioral health agencies have been in the trenches doing social determinants work for a very long time, decades worth of it. Maybe even since before I was born, which is a long time ago. And they've been integrated with a lot of other systems in doing that work as well, right? So when we think about things like jail-based mental health or substance use disorder treatment services, we're actually there already. What we're not doing is availing ourselves of the opportunity of federal financial participation for those services. And because we haven't had FFP, we're really not operating to scale with consistency and stability, right? Shoestring budget, ragtag, here and there where we can, catch as catch can. So the changes in calaim are really important, but for us, they're different. Where are we starting from as a system? We're starting from that biopsychosocial model that, again, uniquely positions us to be elbow deep in social determinants work, but we really have been left behind when it comes to operating like full grown-up managed care plans. And that means a lot of infrastructure needs. So I'm going to start with where we sat together with the state in 2019 to really put some meat on the bones behind the calaim vision for county behavioral health transformation. It was pre-2020, and we were looking at what problems are we trying to solve for? What's holding us back as a system? And the very first thing that we came to was, because of the way that we self-finance the non-federal share for Medicaid payments as managed care plans, we were then, and we are still today, required to document county behavioral health services for Medi-Cal to the minute. This requirement has been corrosive to our system. From a workforce standpoint, it's taken precious clinician time away from direct services to the point where staff have said, we're leaving in droves. We don't want to spend our time like this. It's also limited the ability of us to really spend enough time with our clients to make the most of the scarce workforce that we have. And counties have been so focused on compliance and sort of, making sure that we're documenting things properly, that it's really diverted attention away from what's most important for the clients. Another aspect of the way that we're paid is that we are limited to cost. So part of the painstaking documentation that's required was to ensure that the federal government is not providing us with any money above just that basic cost. And so there's been no ability historically for us or our providers to really develop a profit increment or reinvestment into our system. And we are at significant risk for recoupment. So every year we go through a cost resettlement process with the state. And actually, we go through a mini version of it with our providers. So we might self-disallow if we say, oh, it wasn't really that you didn't offer a legitimate service to a legitimate Medi-Cal beneficiary, but because we didn't dot the I's and cross the T's in the ways that CMS and DHCS are looking for, we're going to disallow that, say it didn't count, right? And we have held significant risk year to year to the tune of hundreds of millions of dollars, and are in some cases reconciling claims as back as a decade. I don't know about you, but I can hardly remember what I ate for lunch yesterday, let alone what my organization did 10 years ago from a fiscal standpoint, right? For these reasons and many more, our counties have embarked on a multi-year effort to overhaul how we get paid. This is the Behavioral Health Payment Reform Initiative. Now get this, phase one of this effort is to make the radical move from cost-based reimbursement to fee-for-service. You heard me right. In 2023, we are shifting into fee-for-service reimbursement. The state's methodology is to move us to a plan-based fee-for-service rate and to have our counties then negotiate rates with our providers. We're on an extremely aggressive timeline. And it's of course been complicated by the pandemic, which has put a tremendous strain not only on our workforce doing direct service care, but also on the back end of the house. And, it comes at a time where there's so much attention and focus on behavioral health that we have many concurrent initiatives happening at the same time. Now, the state's plan with us is not to spend too much time in fee-for-service land before we move and transition over to risk-based capitation. We are at this moment still in the process of receiving draft rates from the state and working on modeling those. But then in the next 4 to 5 months, we're going to have to renegotiate roughly $6 to $7 billion worth of Medi-Cal specialty behavioral health services within our county operations and with our contract providers. It's a massive lift. In addition to this fundamental change in how we pay for services, we are also undergoing concurrent transformations in county behavioral health that are tied to calaim. The first is that we've revised our eligibility criteria, meaning who gets in the door for county behavioral health services. It used to be that our state required us to impose a diagnosis on an individual before we could determine them eligible for services. County behavioral health directors identified this as a problem and advocated with the state to remove this eligibility criteria, in part because we knew we were leaving federal dollars on the table, and in part because it doesn't square with clinical practice. It's not always possible for clinicians to know with 100% auditor approved certainty what's going on under the surface day one when you're seeing a client. It also doesn't mean, again, that the services that we've rendered aren't valid and medically necessary. We are at the same time implementing no wrong door policies, standardized screening and transition tools. And these really try to sort of advance this notion of patient-centeredness for Medi-Cal beneficiaries, that if you need this service, it doesn't matter where you start, you're at the right place, and we'll get you to where you need to be. While we've implemented some documentation reforms as well, as I've mentioned previously, the real game changer here will take place in a way that's tied back to that to-the-minute payment reform initiative. So more to come on that. And on the horizon, counties are also working with the state to merge our specialty mental health plan functions and our separate and distinct SUD, substance use disorder plan functions. This is called administrative integration so that we don't have to run two parallel and distinct systems for the purposes of our relationship with the state, right? Right now, we're undergoing parallel processes for things like our external quality review and other compliance efforts. Everything is separated, even within that county behavioral health agency umbrella. We're working with the state very closely to make significant improvements in outcomes and access for our clients as well through a new 1115 demonstration called CalBHCBC. And this would allow county behavioral health agencies to tap into new Medicaid reimbursement for things like community health workers who may do outreach and engagement, as well as limited term housing, and to encourage counties or as well as employment services, and to encourage counties to operate programs like ACT and FACT, which are assertive community treatment, to fidelity. So there's a lot happening on the horizon as well. In exchange for some of these, counties could also receive some limited reimbursement for for inpatient or residential stays in larger facilities. Since the inception of Medicaid, inpatient and residential treatment for behavioral health conditions has been excluded under something called the IMD exclusion. So again, these would be for short-term stays only under 60 days with an average length of stay of 30 days. We could potentially receive some reimbursement under Medicaid, and that would be pretty major in certain parts of the state. Finally, we share the state's excitement in becoming the first in the nation to get CMS approval for jail in-reach services so that individuals who touch our county jail and state prison systems can be better connected to county behavioral health services. We're working very closely with the state on that. And again, we have a presence in many jails. This is just a game changer in terms of allowing for that federal reimbursement. I would be remiss if I didn't express that this is a uniquely challenging time for us, not just because it's happening at the tail end of a devastating pandemic and the worst workforce and crises, housing crises that we've seen. I think we're actually past the point of crisis and maybe into catastrophe territory there. But we're also experiencing an unprecedented time of focus and attention on behavioral health transformation overall that's been spurred by our growing public awareness of the need to support children and youth, our fentanyl crisis, and the needs of individuals who are unhoused. The public is simply asking for more of our safety net. We don't necessarily have more people or capacity to deliver on these promises. The urgency of this moment is real. Their concerns are real, but we must do better now. And given the reality on the ground, the question is how. While the state has had the foresight to invest significant chunks of one-time surplus into infrastructure and workforce, as the county behavioral health safety net, we're not necessarily the direct recipient or the largest recipient of those funding opportunities. Instead, as the system grows, we'll be expected to sustain that growth, but with the same overall funding inputs allocated by the state, not adjusted for higher demand, higher acuity, and frankly, inflation and market competition. I've always thought that behavioral health markets were fundamentally different, and the last few years have proven just how true that is. For me, the promise of calaim is that by expanding Medi-Cal reimbursement to touch more of what we do as a biopsychosocial system that for decades has touched schools, carceral systems, housing, and social services, that our state Medicaid agency will both support our growth through new opportunities for federal financial participation, while also gaining better insight into the strengths of our system and changing our relationship with the managed care plans, our providers, and ultimately our beneficiaries and communities that we serve. There's a lot more work to be done. Thank you.
Thank you, Michelle. The next speaker I'm going to introduce is Craig Cornett, who's the CEO for the California Association of Health Facilities. But really, we all think of them as skilled nursing facilities throughout the state. And I have to say that in my time working on health policy issues in the legislature and outside, the issue of long-term care is one of those things that we also kind of, just like behavioral health, we don't put in the forefront. And part of that is because it's complicated, because so many people are Medicare. And for those of us that work on state policy, Medicare is one of those things that we're just like, I don't know what the hell that is, but we know a lot of people have it. Long-term care services also tend to be excluded from the core of the healthcare delivery system in many ways. And so the integration and the focus for this population is really important. And I think it's there for reasons, high cost and complex cases. And it's not just old people. You know, the people who are going in and out of nursing homes now are, as Craig, I think will attest, a variety of people who previously had been spending more time in hospitals, but they're now moving into these settings where they can get more of these kinds of intensive services on their way home. So, Craig Cornett.
Well, thank you very much, and thank you for the opportunity to be here today. And just to say, if you have not heard David and his band, I strongly urge you to do that. They are terrific and a great evening to be had whenever you can see them. So I am here representing two populations that are being carved in to long-term care populations that are being carved in managed care under calaim. And that is the skilled nursing facilities and also the intermediate care facilities for the developmentally disabled. And just in terms of level setting, let me just start out this and give you a little quick overview here. There are about 1,100 to 1,200 skilled nursing facilities in California, all over the place. They serve about 350,000 residents every year, patients every year who pass through. There are about 120,000 beds. So when you think about that, you realize most people are there for 3 months or less for rehabilitation after hospital stay. But there is also a significant population of custodial patients who are there for a long time under Medi-Cal. The skilled nursing structure in California is almost completely supported by government funds. 2/3 of the funding comes from Medi-Cal and about 1/3 from Medicare. So it's almost virtually no private pay. So that gives you some rough sense. And we have a very high level of acuity in our skilled nursing facilities in California. We are unlike a lot of other states, but in California, we have a very high level of acuity. And if you look at the population we serve, it is very different than it was 20 or 25 years ago. Many people have already been through home-based care on the Medi-Cal side particularly, and have come to skilled nursing, and that is where they will frequently live out the last days of their lives because they are have heavily acute needs and have much more difficulty being treated outside of an acute care setting. I had the opportunity to take some state officials a few years ago through a skilled nursing facility, and the first reaction I got was, boy, this looks a lot more like a hospital. I realized, I'm like, well, that's what our skilled nursing facilities are like now. The intermediate care facilities for the developmentally disabled, there are about 800 or so of those in the state. They tend to serve a smaller population, but that is a population with a very wide age range. And also in most of those facilities are very small, 6 beds or so. So I just want to level set a little bit on that because what I'm going to say now makes a difference in how I think we look at implementation of calaim. And to say at the beginning, my association was supportive of calaim. We think it holds enormous promise going forward. But the rubber really meets the road on implementation with the folks that I represent. And I will tell you, it is a very bumpy road so far. And I think the one thing that we need to emphasize here is, I'm not going to use the plane analogy since David's already chastised me on that, but let me use another one. And that is that when you think about doing a renovation or a remodel of your house, and I've done that, many of you probably have, one of the first things the contractor will tell you is make sure your plumbing is up to snuff, make sure your electrical is working, make sure the basic infrastructure of the house is in good shape to build upon for whatever it is you want to do. That is the concern I have going in, frankly, to calaim, because our nursing homes in California are not doing great financially at all. The latest data on this is that more than 25% are operating with negative margins. Some, about a half of that number, margins of less than of negative 7.5% or more. So we are, and even with our latest Medi-Cal rate increases, our facilities will still be compensated on a fee-for-service basis, audited actual cost at about 17% below their actual Medi-Cal cost. So that's a concern going in to this at the beginning. Now, I would say that we have had a lot of conversations to move forward into calaim. The good thing is about 2/3 of our SNFs in California were already in CCI counties. So they were already part of CCI. And for those of you who went through CCI, extremely bumpy road. And there were a lot of lessons learned, I think, from CCI. And we have tried to work with the state and the health plans to incorporate those lessons learned on the SNF side, at least. I'm going to talk about the ICF separately in a minute because they're a very different animal. But on the SNF side, I would say that the biggest challenges we have had over the years, and we've worked out, I think, a pretty good relationship with the health plans over the years. But like I said, it has been difficult. And a lot of that difficulty comes from, I would say, a lot of turnover in the plans, a lot of difficulty in facilities getting paid, certainly not being paid in a timely fashion. And when you look at these tight margins facilities are operating under, not getting paid is a big deal. And not getting paid in a timely fashion is a big, big deal. So that's one area I think that we've been concerned about. We have been trying to make sure that as the state implements calaim, that its instructions and guidelines to the health plans mirror at least the protections for skilled nursing facilities that were available under CCI. That has also been an unexpected challenge because the state now, I believes under the new waivers and under the directed payment program, it can't be exactly like CCI. So we now have a different set of standards for those facilities that are coming in under calaim than those that were pre-existing to CCI. I'm not sure that makes a lot of logical sense, but it is what it is. We're having to live with it as it is. And for example, issues about rate floors and so forth. In order to have quality care, it does cost money. We know that. And our view has always been individual facilities should be able to negotiate with the plans to provide the level of care the plans need for the patients that they have. The way the department initially put out its all plan letter on this, it said that the rate floor was also a rate ceiling. Well, that was not workable. That was just not workable. Now, I think we've made good progress on that, and I think to a better place on this all the way around. There's another issue too that I think we are struggling with and have struggled with now. As a result of the change with calaim, all skilled nursing facilities in California have to have a contract with a managed care plan because they are the payers. Many managed care plans don't want a contract on an ongoing basis. They want to do what's called letters of agreement or LOAs. That's a very big problem for a different set of reasons. If we have, the state has always had, for the last many years, has had a quality payment program for nursing facilities, which is very important. My association and our sector very strongly supports the quality payment program, which is now known as WQIP, the Workforce Quality and Incentive Program, to try to drive quality enhancements and quality improvements. In order for a facility to be paid any payment under the quality program, they have to have a contract. An LOA won't do it. So that is a big concern, because facilities that don't have a contract will be automatically shut out of the ability to participate in that program, which we think is counterproductive to everyone, frankly. That is a significant, and especially because the state is emphasizing quality payments more and more. And this year's the budget that was just enacted tripled the amount of money in for quality payments. Very important going forward. But we're trying to transition this. This is sort of what I mean about trying to figure out these nitty-gritty details on the ground. Also, significant issues if facilities don't have contracts. If there aren't contracts, I think we are at a much bigger risk in the community of network adequacy. And network adequacy is a very important point to the state and to the federal government both. And so this is also a challenge. So I would say we have been kind of grinding through these issues with the state for the last couple of years, and I think making very good progress. I will tell you that. I think we have already seen that we think there will be an enormous amount of need for enforcement and follow-up from the state. The state, in the past at least, under CCI, I would say is haphazard at best in terms of their oversight and enforcement areas. I think they're getting better on that, but that's going to need to continue. I would strongly suggest. We had an example 2 years ago of only one plan in the state that was not paying for bed holds, even though it was very clear that that was a requirement under state APLs, all plan letters. We got the state to clarify that and put out a notification. It still took that plan another 1.5 years to decide if it believed it. And so that's the kind of struggle that I think, like I said, in what I would call day-to-day struggle that is inherent in this. The other thing I want to mention also on and I think you all know, long-term care, skilled nursing was carved in effective January 1st. So we're in this now. We're in this right now, working through this in live time. The other area, though, the intermediate care facilities for the developmentally disabled, they are frequently overlooked in the care continuum. And that is something that I think always concerns us. And that is because, ICFDDs are operating on a whole bunch of different levels. They're all Medi-Cal patients, so they're operating with DHCS, but they're also, their placements are there because of the regional centers. And so we have a sort of this strange combo of things here going on. They have, for the most part, not been anywhere associated with managed care until this. They were scheduled to be carved in on July 1st of this year. We have been advocating for a long time to get a delay in that, and the state just last week announced it is proposing to delay their implementation until January 1st, 2024. That there is an incredible amount of need for that, because, as I say, moving all of these folks into managed care when most managed care plans have no idea what an ICFDD is, number one. They're getting familiar now. And the ICFDDs have never worked with the managed care plans. We want that very much. And this is a very fragile population, obviously, of people of a wide age range, all with intellectual disabilities. So we're working through that, I think, so far, but this one gives us a lot of heartburn and keeps us up at night. I will say the state has been convening a very good work group on this for a while now, and I think we're working through many of these details. But I think this is the biggest challenge. I think it's just the details as much as anything else. I would say that the last thing in terms of what the future looks like, I think the future for this, for calaim and the long-term care sector is good. I think it has great potential. But I think that will only happen with a continued focus on communication with the state and with the health plans and with the providers, and education and collaboration and a lot of trust. That's, I think, the biggest challenges we have ahead.
Thanks, Craig. Just as a historical point for me, I was thinking as we sort of, before I introduce Brenda Graylish, our final panelist here, who's going to talk about calaim and the justice involved population. I just want to say how I got involved in this particular population of focus. And it was, for those of you that remember does anyone remember the Three Strikes Initiative? 1994, 29 years ago. And at that time, my boss, Senator Bill Lockyer, who was President Pro Tem, who was serving with people like Senator Patrick Johnston, sitting in the back there, they were concerned that the population of people, that the number of people who were going to be entering state prison was going to grow at such a rate that it would result in the cannibalization of the last discretionary chunk of the state budget, which was the University of California, which, by the way, is pretty much what happened. And so our focus as staff people was, well, can you figure out how to make that not happen? And so we got involved in what can you do to reduce recidivism rates for people who are going into the justice system, who are going to prison and jail. And we got involved in issues like the number of people who were seriously mentally ill, and people who had substance use issues, and people who were both, which was, by the way, most of them. At that time, we were unable to get Medi-Cal to pay for most of these services for this population because they weren't eligible for Medi-Cal either in the facility or when they got out, because we didn't have the Affordable Care Act expansion. So the world has changed. Although we still are seeing a high percentage of people who are in jail with serious mental health issues and with substance abuse issues. And so what Brenda's going to talk about is the incredible, and I just want to call out the people who were working, there must be people from healthcare services here today. Yes, if you're okay, one, the rest of them are working, I suppose, are listening, but you know, the accomplishment of getting the waiver approved, the first in the country, is just absolutely astonishing and incredible and exciting. I'm doing work in Alameda County. Are there people from Alameda? Anyone from Alameda County here? Anyone from the Alameda Alliance or Alameda County Health Department? Oh, Jane is here. Just to call out to them, you know, there are about 500,000 people that are going through jails and prison in California. In jail, they're only staying for a short time. And, you know, some of the work that we're doing for Scott Coffin and the Alliance, it's only about 12% that are there for longer than 30 days. People moving very fast, lots of people, lots of opportunities to try to engage them in these systems. So now, sorry.
No, you're not.
But let me introduce Brenda Graylish, who's the Executive Director of the California Council on Criminal Justice and Behavioral Health.
As a DHCS alum, I can 100% tell you they are working. And somebody who's tracking their work, it's just hard keeping up with everything DHCS is doing because it's so exciting and there's so much of it, and really trying to think it through of how it can impact the justice involved population, which is 100% of my job. So I'm Brenda Graylish. I'm the Executive Officer for the Council on Criminal Justice and Behavioral Health. We're a 12-member council chaired by the Secretary of the California Department of Corrections and Rehabilitation, co-chaired by the directors of the state hospitals and Department of Health Care Services. Our remaining members are people who represent criminal justice and behavioral health, who are appointed either by the administration or the legislature. We've been around for about 20 years. So if you haven't heard about us, sorry. It was kind of not as a widely known group for quite some time. I don't think we even had our first official executive officer till about 2014, 2015. There's been quite an evolution in the justice system and how things have happened in the last 10 years. Public safety realignment has just been had a huge impact. How many of you all are familiar with AB 109 public safety realignment? Just show of hands. Okay, that's great. That's great. A good chunk, about half of you. So public safety realignment was basically a realignment of certain types of individuals who were supervised by CDCR to the county probation departments. They're known as post-release community supervision. So now, since public safety realignment went into effect in about 2012, about 50% of individuals released from prison go on to parole, where they're supervised by parole, and the other half go on to post-release community supervision. Another big change happened with public safety realignment, and that was that the parole violations, the traditional parole violations were basically went away. So what really was keeping the prison population high was not only many of the sentencing changes that had occurred over the years, but also our parole supervision practices. So let's see, I was the deputy director of the Office of Research at the time of public safety realignment. If somebody went out of prison, they had about a 65% chance of coming back within 3 years. And so people were churning and just coming right back to prison. So with public safety realignment, many of these individuals are now at our local communities, either being supervised by parole or PRCS and not having their parole revoked to bring them back to prison. Another important change that happened with public safety realignment was some of the sentences changed. So some felonies that would have sentenced somebody to prison now maintain them at the local level. So those are some of the longer sentences that David was just talking about. So most folks who get arrested and put in jail typically are in and out quickly. But there are a group of folks typically called 1170Hs that are serving longer sentences or may serve what's called a split sentence, where they're half served by in a jail sentence, and then the other part is on their probation supervision. So a lot of changes that happened. I was actually at corrections working in their Office of Research when that happened, and was just about ready to move over the Department of Healthcare Services when the former Department of Mental Health split up and the community side rolled into DHCS. So I moved over, and right about that time, the Affordable Care Act was being implemented. And having been working in research in corrections, I thought, oh my gosh, we're winning the lottery. I had just read a study with RAND just showing the importance of really getting healthcare and behavioral health services to the reentering or transitioning population to really maximize their chances of success in rebuilding their lives in their communities and reducing recidivism. And so I remember thinking, oh my gosh, we're winning the lottery here. We're getting access to healthcare coverage to many people who wouldn't have had it before. But then I started thinking a little bit, I'm like, but will they come? Will they actually utilize those services? So one of the things, I actually was a sitting member on representing DHCS for about 7 years on CCJBH before becoming the executive officer. And the executive officer at the time, Stephanie Welch, who's now our Deputy Secretary of Behavioral Health at the California Health and Human Services Agency. And I started thinking about a study to look at information or look at the utilization or Medi-Cal utilization practices of individuals leaving state prison. So we established a data sharing agreement between CDCR and DHCS called the Medi-Cal Utilization Project. And so through that, we are able to track the utilization of individuals leaving prison. Really excited that about 80% of folks who leave prison do get onto Medi-Cal. So that's really exciting. Most are enrolled into a managed care plan within the first few months. So that's also very exciting, especially as we start thinking about enhanced care management and access to those benefits, including and community supports. The other thing is, one of the things we notice is that, and this is going to be a challenge, I think, for all of you, and something I wanted to put on your radar is just because you build it, it doesn't mean that they will come. It requires a lot of community engagement. When we look at the behavioral health services for individuals who have behavioral health needs identified upon release from prison, about half of people with identified mental health designation and or a co-occurring get a service, at least one service within a year of release. And that goes down when we look at actual engagement, which we define as 5 or more services. And then it's even lower for SUD only. It's about 30% that we see. And, you know, some people will say, oh, is it, you know, is there something about the transition? And that could be part of it. But it also could be you know, individuals who are not typically trustworthy of these systems. You know, we have relationships with provider groups who represent individuals with lived experience of having been incarcerated in jails and prisons who have behavioral health needs. And, you know, there's also extreme distrust of these systems. And so really making sure that that's on your radar so that as you're looking to build out these systems and engage these populations, you know, it's really going to be a little bit of extra elbow grease for this population, or a different elbow grease to really want to, or really to engage them, to want them to use these services. One of the things we at CCJBH are doing right now, working with CSU Sacramento, is we're about ready to embark on some focus groups with individuals with lived experience who have behavioral health conditions, who've been incarcerated, to ask them what is it that you know, has worked well for them, what do they want to see more of, what didn't work for them, and you know, what advice, if they could give us advice for how we design these systems, what should it look like? So we're really looking forward to you know, having those focus groups take place. They'll be taking place throughout the state, in about 4 regions throughout the state. So that we can gather their information and what they have to say. And I would actually really encourage all of you who are working to design these systems to do the same. I think it's been really emphasized through our panels today how important and foundational relationships are going to be. So, and that's relationships across, up and down, every which way. You know, when I was at DHCS, I remember JC saying, you know, how absolutely foundational and what a unique opportunity that calaim is to bring disparate systems together, these siloed systems, some who have worked together a little bit here and there, but really in a very formal way to be able to bring these systems together. And just in our work that we've done in terms of bringing some of these systems together, particularly with the justice system, we tend to speak different languages. And so I would say another thing I want to put on your radar is using the same terms, but meaning very different things. And I know this sounds super simple, but it's very complicated and it can cause a lot of frustration. So, you know, and I'll just give you an example, the word services, right? Seems like a simple word. No, like the farthest thing from it, right? Services. I was in a meeting, we were talking, I think it was housing and parole. And here we were using the word services for a good month and a half in meetings, and then realized that we were totally talking about different things, you know, in terms of services. We did a mapping and it just made it so much clearer for all of us. So I know it sounds like simple exercises, but they're huge. Another one, treatment. You know, in the criminal justice world, you'll hear folks use the word treatment. There's this whole field called evidence-based corrections. How many of you have heard of that? Evidence-based correct? Just a handful. All right, that's huge in the corrections world, evidence-based corrections, where you're assessing for criminogenic risk and needs and targeting interventions to address those criminogenic needs. I'll say something like thinking, like criminal thinking, like, oh, it's okay if I, you know, steal from somebody. There's a certain kind of thought process that goes on behind that. And there's a certain intervention that goes behind unwinding or changing that thought process. And there's whole, you know, evidence-based curriculums and interventions that can be implemented. And the research shows that it's not just about the behavioral health interventions, but you also need to pair those with criminogenic interventions. And, you know, you're hearing me use different terms right now because I'll give you the example of what happened with the word treatment between a criminal justice and a behavioral health space. County behavioral health in one county found out that, you know, probation's doing some criminogenic treatment and was like, wait a minute, we do treatment. What are you guys doing treatment for? Okay, that just became a thing. And so after some time and some education, cross-system education, it became, oh, wait a minute, you're doing something totally different. You're targeting criminogenic needs. Okay, maybe they talk about that a little bit in clinical treatment for mental health, but it's very different from what's criminogenic interventions. And so then they began to work together. And like I said, all the research shows that pairing and really doing what's called comprehensive collaborative case planning is what is absolutely needed to really wrap around somebody who's become involved in the justice system and provide those, very comprehensive approaches. And that requires a lot of interagency collaboration and education and patience. And so that's one thing I just want to say is all of you are embarking to, go outside of your own spaces and moving into other fields is having an awareness that there's going to be those differences. There's going to be those, Oprah aha moments of services and treatment and all that good stuff. But having the grace to be very patient with one another, I think will go a long way. Because I know like sometimes that frustration comes up and you're just like, and then you go for the other system. Just stop and say, wait a minute, let's be frustrated at the process, move forward, get through it, and work on it together to achieve that solution. The other thing I just want to bring up for everyone, and it's so exciting that we have 90-day inReach, that waiver again, win in the lottery for our justice involved population. But it's really going to take, we're talking about the provider capacity, it's really going to not be business as usual. I think there's been some wonderful conversations and efforts that are, really catapulting forward to address inequities in our systems. And, when it comes to inequities in a justice involved situation, population, it's quite stark. When we look at just people with behavioral health needs in general, we track, we have to write an annual legislative report. We track the prevalence rates of people with behavioral health needs who are in our jails and prisons. And, it's somewhere around 30% for mental health and about 80% for substance use disorder in our prisons. We can't even say what the SUD is in jail because that's not tracked at a statewide level. And even when we look at the data for mental health in our jails, we're using proxy measures. So that's just kind of an ish. But it's a clear overrepresentation when we compare it to the general population. So something's up there. And so, as a council, we're just looking at that metric and, having looked at public safety realignment, you don't see big swings in data unless there's like a very drastic intervention happen or a policy change. When we saw public safety realignment, prison population, right, way down after public safety realignment, no more parole violators, shut the front door, just see that population declining. So we'd like to see something like that with calaim, with the justice involved package. There's several proposals for the justice involved, and even having justice involved as a target population, I think is important in and of itself, because oftentimes the justice involved population just kind of gets lumped in with everybody else. Like, okay, we're going to do this change, this system change, and it's very broad. And the justice involved is kind of lumped in with that, but then gets left behind and they don't realize the benefits of of those new initiatives, or don't realize it fully, and don't have access to, or don't want access to it, don't know about it, aren't trustworthy of it. So really being intentional about the justice involved population, identifying them, carving out special efforts to provide services to them that they want to receive and feel comfortable receiving is going to be pivotal. I think a big piece of that, I've talked to providers before and I've said, okay, well, if we're going to have to do something different, we can't do something business as usual because then we'll have the system that we see right now, right? So, who's going to help us make this change? And I really think it's the community-based providers. We've kind of nicknamed them at CCJBH the hidden network providers. These providers that are kind of existing, they've been in our communities throughout the state for many, many years. They're funded through grants, or maybe they get some MHSA dollars, or whatever they can get to stay afloat to serve the justice involved population. So that's what they do, but they're not part of our kind of mainstream Medi-Cal, service delivery systems. So, what's in it for them is they can get a stable funding source. What's in it from the system perspective is that those providers can help address those equity gaps that we have identified in our systems, really bringing in those trusted, we call them, those credible community messengers to really help engage this population. And they're out there and they're doing amazing work. One of the things that they do, because I had to ask, like, well, what, especially with the justice involved population, we tend to run into providers being fearful of serving a justice involved population. And I'm like, how do you guys get around that? And they said, peers, people with lived experience, lifers in particular. Some of them said, we've got lifers that are worth their weight in gold. They have that credibility, they have that expertise to really draw in and that population and mitigate issues from happening and getting in front of them. So, with the idea of building out workforce and this need and this big challenge we have ahead of us, where we're saying workforce, oh my gosh, really tapping into the justice involved to be part of that workforce across different systems. So even at CCJBH, we just say it's not just in behavioral health, but in the justice system, in primary care, in housing. They're needed everywhere, and to be kind of those social brokers and folks to help people navigate in a way that they feel safe and heard and can have the trust that they need to improve their lives. I would also say too, in terms of workforce, and I don't want to take up too much time, but in terms of workforce, is a trained clinical workforce. So a workforce that knows how to address the needs of a highly traumatized population who came from, many individuals came from pretty impoverished backgrounds, gang communities. It's very scary, in terms of what they've been through, and then having been incarcerated adds to all of that. And so, and then if somebody's got, say, serious mental illness, schizophrenia, bipolar, all of that, very important to take into account. So it really requires a highly trained clinical workforce to be able to unpack that, and also not just like one person, but like a team of folks to be able to help unpack that. And then housing's huge. I know we've talked about housing before. It's going to be absolutely huge. You want to talk about this, the general pop housing, access to housing, try bringing it into a justice involved, and those criminal backgrounds just icing people out of having housing opportunities. So, really trying to think about how we can lean on our housing partners. Something we've been doing at CCJBH is we're bringing, we've developed partnerships with the California Interagency Council on Homelessness, Housing and Community Development, trying to model at the state level what should be happening at the local level. There's a lot of expertise over there. They know where to find the developers. They know how to do the financing. So bringing that into the healthcare space and having that expertise to help build out these projects. I would say that's basically about it. Actually, that was the end of my thing, David. So anyway, well, thank you all so much and appreciate it. And thank you for all the work you'll be doing for this population.
Thank you, Brenda. Well, I thought I would just ask all of the questions because I have so many at this point, but I think maybe it'd be nicer if I open it up to the audience. So yes. And can you identify yourself for the record?
I don't have it at my fingertips, but we are looking at that. I mean, and we're looking at like two things, Medi-Cal enrollment and plan selection. So I don't have that right off the bat, but it's usually within a few months. By 6 months, we're pretty good. Mm-hmm. Yeah, I think that's what, we'd like to see for sure. Yeah, sure. Focus groups are going to be held February, March, and we'd be looking to publish the findings this summer. February, March this summer. You got it. Thank you.
Just as a follow-up on your first question, counties are now involved in the process of creating mechanisms so they can enroll people in jail So for in Medi-Cal, there's a path funding opportunity with a deadline coming up. So stay tuned for that. But the idea is to get people enrolled in Medi-Cal so that they can access these services. Other questions? Yes, Dr. Cousineau. Can you stand up for did everyone hear the question? Yes, go ahead, Michelle, do you want?
The question that I heard is how care courts will be integrated with calaim. So for those of you who may not have heard, last year, the legislature worked with the governor to create a new civil court process targeting individuals with schizophrenia, schizoaffective, and other psychosis. And it's sort of a court process that's brand new. It'll start with 7 counties plus LA, which are cohort 1 by the end of this year. Then cohort 2 will bring in the remaining counties by the end of 2024. There is a proposal right now under the 1115 demonstration Cal BH CBC to I think it speaks to technical assistance that's going to be provided by the state pursuant to last year's legislation. So the state is looking to kind of highlight the technical assistance and support around care courts as part of that demonstration project, which does fall under calaim, and then to potentially look at some targets. Now, it's a little bit complicated. I think we do have questions, right? If you're looking at a process to try to get individuals into a civil court process, that may be the least restrictive option compared to, say, conservatorship. But we do have questions about how we will fold those things together, right? Because our goal is always to go as upstream as possible, least restrictive as possible. That is our requirement under the law. So how we sort of manage those goals with conservatorship being the most restrictive and care court being upstream of that is a question I think we have outstanding.
It's kind of like building a bicycle as you. Yes.
Hi, Brianna Moncada. I work with Mom's Meals. We're a medically tailored meal provider for community supports. And just wanted to ask Brenda, I know you said that I think it was maybe half of those that are released are receiving services within a year. Is there a plan to try to increase that as we see this become a population of focus in July?
And so thank you for the question. So basically the plan is we report this every year. So we're going to be looking to see exactly what happens as calaim gets implemented. So with ECM and CS, or ECM being available now to the SMI SUD population of focus, we're as CCJBH trying really hard to try to get those connections together and get it out that it's like, you don't have to wait for the justice involved population to become a population of focus before we can start working on that. So so that's one thing we're looking at is just keeping track of the data and just watching to see how this implements. And at DHS, I think is doing the same thing, on as well. They just published ECM data about a month ago. So yeah, that's exactly what we're looking at. We want to see those services start getting utilized more.
Thank you.
Yeah.
And one thing, if I may add, Brenda, that's kind of interesting for us from the county behavioral health perspective is that we do see a lot of where we do that tracking at the jail level. We see a lot of folks with SUD, especially in those very short turnstiles type jail stays. But oftentimes individuals with substance use disorders actually have a co-occurring mild to moderate condition, which is part of the managed care plan responsibility. And so it does take a lot of coordination across SUD and the managed care plans for that non-specialty mental health service. And then the other thing I'll just mention is that the degree to which Medi-Cal covers substance use disorder services really is an interesting story for another day.
I would say in our report, in our ledge report, we split out the managed care plan and specialty mental health services. So we can see the growth on both.
Hi, I'm Dina Lon from the San Francisco Community Clinic Consortium. I'm going to ask a question that's going to sound naive, and it's not. It's real. It is slightly born out of frustration. But when I read about calaim and particularly about behavioral health changes, I end up feeling extremely frustrated because, as far as I can tell, there is this division between the mild to moderate and the severe, and there's now this no wrong door issue. But behind every door, there is not the workforce to support people, particularly psychiatry. So I firmly believe that there are many mental health providers. But in the end, what we find in our clinics, where we serve a lot of homeless and marginally housed people who have a lot of serious problems, people get juggled back and forth between the county system and the clinic system. Clinic system really wants to serve them if they are their patients, but we don't have the psychiatric backup we need to do that. These things are complicated. They're not simple. And I don't think that a nurse practitioner, a doctor, primary care doctor, they need help in serving these people. So we went to our county mental health agency and said, we need some help. You know, you guys used to let us have some psychiatry help. We need it. They said, well, we can't hire psychiatrists for our side of, so we certainly can't, lend you anybody. And in the end, I feel like without this actual accessible workforce, these people aren't being served no matter what door they enter through, or they're not being served to the extent that they should. And I feel like there's a lot of pressure on our primary care doctors to be seeing very severe and complicated cases where people have substance abuse, they have mental health issues, etc. So I just, I know this is somewhat a rhetorical question, but I'm just trying to figure out how all of this moving the ships around and, where people enter is going to help if we don't have the actual people to serve them.
Amen.
I would just say that this is a complex set of initiatives, many of which are overlapping, as we've kind of heard. And it's easy to say, well, we have all these barriers. We have a workforce barrier, we have capacity barriers, we have a housing barrier because many of the people that are being served in these populations are homeless or experiencing homelessness. So, I guess we'll just throw up our hands and, just say, well, we just can't do it. And for those that take that view, we will never have this opportunity again. And so I think the issue and the challenge for ITUP, if I may, is to say that what kind of solutions can we come up with? How do we come together and find ways of using resources in a different way, of addressing these issues? No, we're not going to solve it completely, but can we do a better job than what we're doing now? I think we can, especially with some of the brain power at this table and in this room. I think we have time for one more question, maybe? Yes.
Hey, good afternoon. Can you hear me? Okay, Eva Terrazas with Pacific Clinics. This question is really directed to Michelle. Payment reform is coming. We are an agency, behavioral health agency that operates throughout the state. We know counties are at different places in terms of payment reform, but yet it's coming July 1. So can you tell us about the readiness of counties throughout the state related to payment reform? And I'll just leave it at that. Thank you.
This is going to be an extremely bumpy ride, is what I will say. I didn't get into all of the weeds. I got into the reasons why we're doing payment reform, because I think it's going to be very important for us to hold that as our North Star as we try to turn this around. I I do think that better days are ahead once we get there. But there is an extremely short runway for us to fly this plane, right? And so it's going to be tough. And in terms of readiness, I mean, again, we are still getting the drip of new rates in, and county government revising contracts and the mechanism for how we draw down our, funding, in addition to, I didn't mention all the details. We are changing how we're coding services. So this is a federal requirement that is happening concurrently with the shift in reimbursement. So it's just, all I will say is, with any luck, we'll get through 2023. And we won't break the system. And then hopefully, we can get to a better place once we turn the corner.
All right, well, let's thank our panel, Craig, Brenda, Lisa, and Michelle. And I'm going to turn it back to our leaders here.
Thank you, David, and panelists. David, challenge accepted. We heard so many great insightful comments, and it's clear that we have a lot of work to do, and it seems like there's so many details that we need to build up to really make calaim meaningful and work for the communities it's supposed to serve. So with that, we have a little bit of a break. So we're going to come in for the second panel at 2:30. So there's refreshments out in the hall, and we'll see you all back in here shortly.